So now that we understand normal function, let's talk about the first and most common weight loss surgery, the vertical sleeve gastrectomy, also known as the sleeve. The sleeve is done with a total of 5 incisions across the belly. Let's don't get married to the notion of these incisions being right where they are in this picture. So incisions are placed where they need to be placed for surgery to be done safely and efficiently. Factors such as your own body habitus, size, makeup, for example, having a shorter abdomen and a longer chest, as well as the presence of previous surgical scars around the belly or coming up and down the middle here, will affect where these incisions are placed. But generally speaking, we're doing this with 4 small incisions across the belly, 1 under the rib cage. This one in particular, I'll go ahead and tell you, is usually not here in the middle. It's off to the right side. It can actually be anywhere from 1 centimeter to 2 centimeters or 2.5 centimeters long, because it's the site where once we're done cutting on the stomach, we remove that part of the stomach. It's also usually the most common source of pain after this surgery, again because the most work is done through that incision. Now, this surgery takes 45 to 60 minutes to complete. We cut and remove 2/3 or 3/4 of the stomach forever. That's this part right here. And in doing so, we leave you with a rigid banana-shaped tube that acts as your new stomach. So this is the sleeve. And the reason this surgery works is A, when we cut and remove this part of the stomach, we're removing the stretchiest part of the muscle fibers. We leave you with the less compliant, less stretchy muscle fibers here. So this rigid tube is, quote, restrictive, because food hits this thing and it won't stretch, it won't give, and you feel full even with a couple bites of food. So that's why it's called a restrictive surgery. Notice we don't do anything to alter the mixing point. That star stays right there. Food still travels down that stomach, gets lightly processed and spit out into here, where it mixes with those digestive enzymes from the pancreas and the bile from the liver. You still have 16 to 20 feet of intestine from here to here to get every little calorie out. I call it the most physiologic surgery for that reason. Now, why is this metabolic? I'm going to explain that on the next slide. But the really, truly remarkable hormonal component of this surgery, the metabolic part, I'm going to explain in a moment. But generally speaking, this is what it looks like when you're done. And again, we don't do anything to manipulate intestinal length. So what are the benefits of the sleeve? Let's talk about that. Basically, in addition to being the most commonly performed surgery, because it is relatively speaking the safest surgery and quickest surgery to perform, so especially if you're coming to the OR table with a lot of prior medical problems, a little bit older, and subtleties in how long the surgery takes actually is a big deal. Typically this is for our heart failure patients, or older patients, then it can factor into what we're trying to accomplish, right? It was classically described as a strictly restrictive procedure. I think that was, to be honest, kind of an old school way of thinking. It's not that it's untrue, but it actually works in so many additional different ways that we've learned about in the last few years. Like I said, that rigid, non-compliant tubular stomach is now prone to getting fuller faster. Only a couple bites of food, especially that first few weeks, months, you'll notice like it takes such a small volume of food for you to feel full. But beyond that, it's metabolic too. So this to me is like kind of the magic of the sleeve, right? So that part of the stomach that was removed, it wasn't just some sack of potatoes or stretchy muscle fibers. So the stomach's job is not just to be a stretchy muscle. It's actually a complex organ. It's lined in the inner lining of the stomach with a variety of cells that make a variety of hormones, proteins, signaling molecules, and other things. So one of the key hormones that's made in the stomach is called ghrelin. So the majority of the cells in our body that make ghrelin, we believe, are housed in the stomach. There are some cells also in the first part of that small intestine, but the bulk of those cells are in the stomach. And we remove that cell volume with the stomach when we remove that part of the stomach. So ghrelin, you may remember from the first slideshow, is the key circulating hormone that controls our hunger in that key hunger and satiety control center in our brain. So by removing the cells that make that hormone and dropping those hormone levels way down right after surgery, we're effectively eliminating by a large degree, a large factor, your hunger stimulus before meals and in between meals. Through more complex biochemistry also, we're learning that ghrelin, potentially other hormones too, by removing ghrelin, we're actually resetting that what I call the metabolic rate thermostat in the brain too. Remember, normally when you were trying to diet and metabolic adaptation kicked in, we had mechanisms that drove up our ghrelin levels to make us more hungry. We also had something causing our metabolic rate to drop down so that we couldn't lose weight even though we were trying as hard as we could. So right after surgery, and this is kind of the magic of the surgery, when you're done and you're getting off the OR table for the first time in maybe years, if not decades, we have very physically gone in and dialed that metabolic rate thermostat up so your metabolism is way higher than it's ever been. Maybe not right after you get off the OR table, but we think based on experiments by about month 2 after surgery to about month 11, 10, 11 after surgery, that metabolic rate is set higher than it's been and it stays there. That's when I tend to say to get the most bang for your buck, you need to be exercising. Because again, you want to take advantage of that high metabolism while you have it. Unfortunately, the body will try to adapt and figure out ways to bring that metabolism back down. But the true reason why in the first year after weight loss surgery, the sleeve can be at times as effective as what would appear to be a more drastic surgery like the bypass, I think it's because of this metabolic component. And for some people, that's all you need. You just need that first year of tremendous restriction and a high metabolism to reset yourself. Get back down to that healthy weight, reform new habits, reprocess, rethink the way you look at food, smell food, prepare your food and enjoy your food, and hopefully you create a lifetime of new habits, and then you can use that tool, the sleeve, and all these weight loss surgeries, they're just tools to maintain your weight loss. So that's the metabolic reason I think that this is such a great surgery. But again, those metabolic effects don't last forever. We do know that the metabolism will come back towards your baseline levels. It does tend to live at a slightly higher level than a true baseline, but it's not going to be way high like it was for those first few months after surgery. 75% of patients have a significant improvement in medical comorbidities, other medical problems that you may be seeking treatment for, high blood pressure, high cholesterol, sleep apnea, you name it, diabetes as well. 60 to 80% excess body weight loss is what you can expect with a sleeve gastrectomy. What's excess body weight? That is your current weight minus your ideal body weight, which you can use an online calculator to figure out. That's the weight we're trying to work on, and you can expect anywhere from 60 to 80% of that number to come off after surgery. Some people exceed the 80%. It tends to be my younger, more active patients. Some people don't even get 60%, right? This is a wide range because this patient population that we followed includes a wide variety of people. So that includes different ages and different levels of, again, these comorbid diseases. Sometimes we have someone getting a weight loss surgery just to qualify for a heart transplant. Oh my God, that patient's not going to be able to benefit from extra effort-related things like exercise, right? So their weight loss is completely reliant on maybe this metabolic part and a little bit of the diet. So you got to realize when we say 60 to 80%, you're going to fall somewhere in that range. Hopefully, I've seen people be disappointed by the results. They didn't even fall in this range when, I'm talking to them, it seems like they should have. So then brings to question, are there huge genetic components to this that we don't fully understand yet? Or is the patient being totally honest with me or themselves too in terms of what they've done to retailer their habits, right? Again, all these surgeries are just tools. If you don't use them properly, you're not going to get the results you want. But sometimes there's factors other than the things that we can control that are at play. Generally speaking, this requires a one-night stay in the hospital to make sure that the initial part of your recovery is going well. I'll tell you, if you're relatively younger, relatively lower BMI, if you don't have a lot of medical conditions, you have a good support system at home. Some places we are doing these things outpatient surgery, so you go home the same day. Maybe something like that will be available soon in the Atlanta area. But as of now, we want our patients to stay a night, and that's probably for your benefit, right? To have an extra set of eyes and a hand to help you get acquainted with your surgery pains, your incision, and just to make sure you're safe with like an extra, an extra set of labs in the morning, and check some boxes before we send you home.